Hi, everybody. Today we're going to be talking about nutrition and obesity issues. And I believe if I switch this over down here in a second, we will have the slideshow being recorded. Okay, so there's obviously much bigger than a short lecture if we're talking about obesity and nutrition issues. But this lecture is specifically a little bit about malnutrition, anorexia, and some of the complications that occur from being obese chronically over time. Let's start out talking about malnutrition. Not a common illness in the United States, starving version of malnutrition, but it still happens. And we don't recognize it, or we're not looking for it. I had a pediatric patient, she was about 2, and whom came into the hospital setting and literally had the $100,000 workup because people had trouble figuring out what's wrong with her. Her mother probably had schizophrenia and was taken away from her because she was ill, and it took a while to realize she was malnourished. And I remember the mother came visit her one day and saw her, smiled real big, and handed her a lollipop. We're like, no lollipops. She goes, so we're talking to her, and she said, well, I can't make her eat the things I don't eat. And we're like, whoa, okay. So causes of malnutrition can be mental incapacity. This can be in the elderly. This can be in the simple mental illness individual, as this woman, or neglect in the case of the child. In this case, the mother was mentally incapable of caring for the child properly. It can just be ignorance. We had a woman showing up, looked like just a run-of-the-mill, middle-class woman showing up with her toddler in the plastic bucket for open heart surgery counseling, and we all looked down and like, holy moly, the baby had a baby bottle in her mouth with Coca-Cola in it. And we just the secretary saw it first, and she's like, look, and I saw it, but wow, about the time the surgeon comes in, he blew a gasket, just started lamming into this mom. I'm like, okay, calm down. It's just ignorance. She drank Cokes. She didn't realize it serves zero nutritional purpose. And we can go on a whole talk about Cokes. Anyway, the elderly, sometimes their teeth are problematic, their sense of taste, difficulty swallowing, things become a problem. And just the burden of planning and organizing meals that used to be so simple when you were younger, or fun when you were younger. I have a couple elderly in-laws, and literally they eat almost the same thing every day. Well, because they're 93 and 95, it's too complicated to plan more. He's short of breath, he stands up for too long. The elderly's at risk, certainly the homeless, for a myriad of reasons. And then we'll have the patients with underlying illness. So they'll be cachectic, or we call in children failure to thrive. And then there's poverty. So in the third world countries, which we call underdeveloped nations or third world countries, the wealthy tend to be obese and the poor tend to have malnourishment. In the United States, in general, obviously this crosses all lines, the poor tend to be obese with not healthy nourishment, and the wealthy and the upper middle class tend to spend more time working on themselves or have social pressure to look good. So you're more likely to see that group with better nourishment. And they can afford it, of course. It is cheaper, or it is not cheaper, but it is cheap in the United States just to drive through someplace and pick up 2 tacos for $1.50 than it is to buy fresh ingredients and cook it and have a healthy meal. If an individual is actually malnourished, some of the signs and symptoms you'll see are listed here on your screen. Lethargy. Their skin will actually be hyperpigmented, dry, and more likely to be wrinkled. So think of the National Geographic magazines where they'd show pictures of a starving nation sort of look. The hair will be much thinner and duller. Think about the commercials of shiny, healthy hair. Progressive, over time, will have loss of muscle mass and subcutaneous fat. If they have low intake of calories, so will actually look what we call cachectic. Okay? Think of just the heart failure infant, they're just scrawny and cachectic. So there's 2 types of malnutrition. There's marasmus, which is overall poor calorie intake. So overall, whatever they're eating, they just don't have enough of it, and it's low, not enough calories. Okay. Kwashiorkor, if I'm pronouncing that correctly, is actually poor protein intake. So you think of a country where they may only have a porridge to eat, or rice. Rice is the mainstay for a lot of the world, so all they have is rice, but yes, they're getting enough calories, but they don't have enough protein in their diet, and other things. Those who live on the nutritional edge will have stunted growth. So I remember a student grew up in Vietnam. She came to the United States when she was 13, and she was little. She was like half my size. A big woman. She had little hips, and she was a 00, on clothing. And she said, well, I said, we were talking about this issue, and she said, well, I grew up in Vietnam, so, we're kind of living on the edge. She said, but all my cousins that were born here are big. They're 6 foot tall, and so they met their genetic potential. She never met her genetic potential. If a child is obese, and you see this in America now, they will grow bigger and faster than their compatriots, their fellow classmates. But they finish out faster. They meet their they close out faster. Their bones will close up sooner. So they may be the tallest kid in 6th or 7th grade, and then everybody surpasses them later on. So stunted growth from malnutrition. This classic starving child protuberant belly look, where they're skinny everywhere and they got the gut, and that's really from muscle hypotonia. They just don't have enough muscle strength from poor nutrition. Depressed heart rate, blood pressure, and temperature, so their body's sort of living on its edge. Certainly immunocompromised, and if decreased protein, they'll be edematous as well. As we know, protein, albumin in your bloodstream is what keeps fluid in the vessels. This can occur if a person's ill and poor protein intake. So maybe they're not in a poverty situation, they're just ill and their intake is fairly low. With the skin darkness, is sort of interesting. That's actually from a substrate, tyrosine. You don't have to write this down, but it's interesting. And coenzymes. You need these enzymes for formation of dopamine and chemical reactions in the body, which don't occur well when you're malnourished. Okay, now you'll notice I'm only having one slide on malnourishment because it's not. Poor nutritional status is pretty high in America when people eat McDonald's for lunch and Taco Bell for dinner, but downright malnutrition isn't as common, but we'll see it in the ill. A little bit about anorexia nervosa. This should be covered in your psych lecture as a psych illness, but we're going to talk about it here because it has a physiological effect. It's defined literally as an obsession with food and an acute anxiety over gaining weight is anorexia nervosa. Bulimia is actually binge eating, then you vomit to compensate, so you purge. So looking back, my freshman roommate in college maybe had some bulimia. Because I remember coming home one day from going out and she was in the bathroom vomiting, and I'm like, what are you doing? Are you sick? She goes, no, I just ate a whole bag of Doritos, so I had to go throw up. And I'm like, okay, that's weird. So potentially bulimic. Well, in the picture here you see the anorexic is seeing themselves as, I just took the same picture and stretched it, sees themselves as this fat person, but in reality they're the incredibly skinny person. So their image of themselves is distorted. When they look in the mirror, they don't see what you and I see. The reason anorexia is important with the pathophysiology is literally it affects about 2.5 million Americans. It has the highest death rate, mortality rate of any mental illness. Literally 1 in 1,000 females have developed anorexia. Half of them get better. Half of them get better. In other words, some people get over it. Others have to fight this throughout their life. And 10% literally die of the illness. About half of all anorexics have bulimia as well. So it's not uncommon to move on to both. Now, why? Who has this? There are triggers. Okay. They believe it's probably environmental stress or trauma in your life of some sort. The stereotypic person we think of as an anorexic in America is the upper middle class or upper class white girl, because she may be under a lot of social pressure to be a certain way and be a level of achievement. But you also have to think in America, a place where you can move up the ladder if you work hard and you're a go-getter and you're aggressive. The type A personality, the parents for the type A personality would have been more likely to be the successful person. So it's that same mental type A personality that the children would have as well, potentially. So now what we've seen over time is anorexia, because America's had a big mix since the 80s, much more ethnic groups come into the area, that it's covered more ethnic groups. You'll see it in a variety of ethnic groups, sometimes males as well, even though stereotypically we think of it in the upper class white population. There's a susceptibility of, I say, use these words loosely, of choosing this illness. So if I have stress and anxiety, if you look back in, I don't know if any of you guys took abnormal psychology in college, and probably, if you guys do, it probably dumbed it down, but when I took it, they were a little more honest, let's say. And there are fashion trends over the centuries of mental illness. One of the lectures we talked about in the 50s, it was popular, use that loosely, to be paralyzed when somebody had some horrible trauma. Like in the burn center, they had a problem with people, because you're disfigured when you're burned, then they can't get up, can't move around, they're paralyzed, they had to force them up because it was psychosocial. So they believe the propensity for this illness may be based on one's natural brain chemistry and their genetics, why you had this type of mental illness versus something else. They also believe that depression and obesity can run in families. And there's an underlying, obesity, that's true too. Obsession, so to have an obsessionist personality. For example, Tom is a partner in his company. Well, he was a gold medalist winner in the Pan Am Games. He has run ultra marathons, and he made partner of this company. So he's this go-go type A killer person. He coaches rowing now. He's like a superstar. His daughter got a full scholarship. Two of them got full scholarships for rowing. So it's a superstar mentality. And one of his daughters, anorexia. And of course, underlying depression, it's this obsessiveness nature in the family. Extreme dieting is a way to exert control in one's life. Because if you had a social issue in the family or some sort of trauma you might not have had a control over, food is a way, they can't make you eat, right? Way to control things. Or act out frustrations of not being perfect. Because that high pressure environment, what you think is perfect, or what somehow you've decided what perfect's supposed to be. So some of the anorexia theory is that starvation, the pathophysiology, not the psychosocial per se, it's a form of self-medication. Now, I obviously don't suffer this illness. I'm thinking about eating lunch right now. But for some people, it feels good, so to speak. In the normal levels of serotonin, to have that normal level, are associated with feelings of well-being. So most of us live naturally at the normal serotonin level. The level of serotonin activity in the brains of anorexics is abnormally high. So this may be just a genetic propensity, that go-getter, anxiety, gotta achieve, and obsession, natureness. I don't think that's a word, sorry. Anyway, it's highly abnormal, so they feel anxious. When you starve yourself, it actually prevents tryptophan, which is an amino acid used to produce serotonin, from getting to the brain. Remember when you eat that big turkey dinner, you're just all relaxed, you want to take a nap. It's tryptophan. Thus, it produces a sense of calm. So if they starve themselves a little bit, they feel less anxious. Increased levels can lead to anxiety. Increased levels of serotonin can lead to anxiety or obsessional thinking, which is classic traits of the anorexic. Now, bulimia, on the other hand, To binge and then to purge also eases anxiety. So if you ingest large amounts of complex carbohydrates, which sounds really good to me right now, raises the brain's serotonin. So you start feeling anxious. Thus, with an increased carb intake, that some people have the propensity to panic about weight gain. The panic sets in, then, okay, now you're panicked. Well, guess what? When you vomit, you release vasopressin, which is a natural sedative. So gorge. Panic sets in, vomit, start feeling better about it. Without this sedative, i.e. not binging and purging, this group can have anxiety set in. When we think about the anorexic, there's a large group of things that can occur from chronically abusing yourself in that way. And this is just a chart to kind of go over some of that stuff. Brain and nerves, they can't think right. And there's tons of studies about this. School-age kids, if you eat breakfast in the morning, you do better on tests. All of you in this class, eat breakfast. I had one student one semester, and because it's a little fashion trend right now to starve yourself to fast. He was fasting during nursing rotation, which was just insane. And he's working a 12-hour shift. Well, guess what? He made an error. You know, not very common for students to make med errors. He made an error. I'm like, now will you eat? Because they kept harassing him. You need to eat. So you can't think straight. They have the fear of gaining weight. They may be sad or moody and irritable. Bad memory, fainting, and changes in the brain chemistry. When I used to date my husband, you know, when you're dating, you tend to get picked up at 7 or whatever, and you go out and eat a late dinner. Well, he learned quickly, you gotta feed me early, man. Don't feed me dinner at 7. You gotta feed me 5 or 6, or I'm gonna be cranky. Anyway, hair. Your hair thins and gets brittle. Heart rate, lower blood pressure, slower heart rate, potential for palpitations, SVT or PAT, and heart failure. Blood-wise, obviously you're anemic, you're malnourished, and potential other blood disorders. Muscles become weaker, joints swell, higher risk for fractures and osteoporosis. I knew a woman who had been anorexic in her teenage years, and she had to have a hip replacement about age 32 from osteoporosis. Who gets osteoporosis at 32? Well, she'd been malnourished for years. Higher risk for kidney stones and kidney failure. Body fluids, electrolytes, low potassium. Some of these patients will manipulate things. Like we had a woman that was taking Lasix and diuretics and anti-constipation meds. Well, if you start messing with your intake output, your electrolytes mess up. Magnesium and sodium issues. Intestines-wise, constipation, not eating enough, and then when you use a lot of fleets enemas and things to make yourself go to the bathroom, then your body gets more dependent on it. So you have more constipation and bloating issues. Hormones-wise, generally the period might stop, bone loss, problems growing because you don't have enough nutrition, trouble getting pregnant. If they get pregnant, there's a higher risk of miscarriages, needing a C-section, having a SGA baby, small for gestational age, and postpartum depression. So eat after you deliver, you'll feel better. Skin-wise, they bruise more easily, dry skin. The lanugo type of hair, growth of thin, fine hair all over the body. They'll get cold easier, and because they don't have the subcutaneous fat to protect them. Yellow skin and nails being brittle. Okay, so some of the complications for anorexia is trouble staying warm. And also you'll see a classic anorexic wearing big fluffy clothes so people don't notice they're so skinny as well. Estrogen and testosterone drops. If a child is anorexic, there'll be delayed puberty. Borderline eating in a growing adolescent can have permanent repercussions. The bones, as you're growing, are getting thicker and longer, and your heart's getting stronger as an adolescent. And your brain is actually still adding mass. So it's very dangerous to have borderline nutritional status during those years. And think about all the junk food junkie kids out there that are trying to grow as well. Stress hormones, cortisol become more elevated, so the bones don't harden as well. And their body ends up consuming muscle from malnutrition. Your nerves and your brain tissue needs fat to grow. You have to have fat in your diet. So atrophy can occur of the brain. There's specific complications for bulimia. they're more likely to have erosion of the tooth enamel. I read an article, I think it was in Wall Street, that UC Santa Barbara, the bathrooms right outside the cafeteria, they have to change the plumbing every year because so many people go eat a big lunch in the cafeteria, and they'll go, so many girls, the girls' bathroom, and they it erodes the plumbing. That's horrible. Anyway, swelling of the jaw and neck from repeat vomiting, irritation or rupture of the esophagus, acid reflux, and ipecac poisoning if they're using a medication to help themselves vomit. Electrolyte imbalances leading to potential for arrhythmias or seizures, because if you vomit a lot, you can potentially lose potassium. Treatment-wise, this goes back to your psychosocial, treat the underlying depression and anxiety. Family therapy is a help to face stresses at home. Psychotherapy addresses the underlying emotional issues of obsession, compulsive behaviors, and this profound rigidity on the way I am, or the way life is, or the way life should be, and perfectionism. Now, some of us don't suffer from that. I definitely don't, but it is a depiction of this crowd. Inpatient treatment centers, if it's bad enough they get admitted, they can downright, tube feedings, IVs, weighing the food. Okay, what did I serve you? What are you taking away? And certainly try to find reasons for the underlying obsession. One of the things to point out, if you stumble somebody in your life or in the hospital setting that is a child, an adolescent, once they turn 18, you can't incarcerate them to treat their anorexia. They have the legal right to starve themselves as an adult. So it's really important to intervene as early and fast as possible. At home, careful food monitoring. And there's this called the Maudsley approach for feeding. It's kind of a contract basis that seems to have a reasonably good success. 50% of patients are helped with cognitive behavior therapy, interpersonal therapy, mixed with antidepressants. Okay, so that's like a quick, fast overview of some of the pathophysiology, med-surg information related to anorexia and bulimia. Now we're going to go to the bigger world of obesity, which is just full of large puns that we can throw out there. So one of the things we have to deal with in the medical setting is addition to the sheer cosmetic undesirableness. So watch the history video. It's gone up and down whether being more voluptuous is considered sexy or not. And right now we're actually on a bit of a turn where being lumpy or more obese is more acceptable than it used to be, because you'll see girls out with really tight jeans with a massive bottom and a muffin top, a roll, and yet they're wearing a half top, so they feel sexy. So it goes up and down on socially how acceptable this is, but in general, people make fun of being fat, okay, or obese. But we can't, it's a psychosocial thing. We have to put that over here because for healthcare reasons, we want people to understand the risks of being chronically overweight or obese. So it's this in-between world. Whether you feel pretty or not is psychosocial up to you, right? Or what society dictates, that's a whole nother issue. So people will say, well, I come from the fat family. I'm fat because it's my genetics. My whole family's fat, and just that's the way it is. Well, okay, and there are genetic obesity genes that some people may have more propensity than others. But if you look back at the 1950s and 60s, it was very uncommon for people to be obese. It just wasn't the norm. So one of the biggest comments to take back to people is, you may have a propensity for obesity genetically, but we're choosing to express it in our lifestyle. So genetically, things don't change in 20 years or 30 years. But yet in the last 20, 30 years, we've just had more and more obese people. So it's our lifestyle that's influencing it. And people need to understand that, so they don't just say, well, I'll give up. I'm just going to pizzas every night because I'm prone to obesity, right? So there's choices in eating and physical activity. This predominantly contributes to excessive weight. In some people, there are multiple genes that may increase susceptibility for obesity, but you have to have the outside factors. If I exercise and I'm an athlete and I eat super healthy, I don't care how many genes I have, I'm not going to be overweight. So this abundant food supply, you know, even if you're poor, you're not that poor compared to, let's say, the Great Depression, right? And little physical activity. Everybody used to walk to school. It is uncommon to see children walk to school nowadays. People used to take the bus to work. Your average married couple in the 50s had one car, right? People walked where they went. Kids ran around the neighborhood. It's uncommon. Nobody sat around and watched television or video games or stared at their cell phone all day and night. So the environment's changed a lot. The obesity way actually started in about the 70s, but the genetic of the population, as we know, cannot change that rapidly. If you go just, to my parents' generation back, my dad was a kid. He grew up in Miami, Florida. Everybody had, of course, you had an ice box, and the Iceman, I guess, came once a week, so you couldn't keep things. You didn't have Tupperware. There were no frozen foods full of salt and cheap oils you could buy from the grocery store. There were no fast food restaurants. Everybody had a garden in the backyard. And then everybody had chickens. He lived in a big city, but you had chickens in your backyard. So evidently, you ate eggs all week, which, by the way, are quite healthy. And then you'd render one chicken on Sunday, because that was a big meal. You were pretty healthy. And then, from his stories, it sounded like they just took the boat out all the time. They would paddle around the canals. The kids ran amok and fish. So, fat tissue, a little bit of physiology here. Fat tissue directly makes inflammatory agents. So it's not just sitting there on your waist or your hips. It's interaction. It's an organ, and it sends out hormones. It's communicating with the rest of your body. Fat tissue attracts macrophages and promotes inflammation. So now we talk about cardiovascular disease. The underlying biggest issue of cardiovascular disease and stroke is inflammation. So inflammation is now viewed as a key to heart disease. Inflamed plaque is more likely to crack open, cause a clot to go showering off. Fat cells also produce plasminogen activator inhibitor 1, which blocks the ability to break up clots. Great. Think of this picture we're painting. Fat cells also produce angiotensinogen, which is a fun word to say. This leads to high blood pressure. So you're getting hit on multiple levels with an imbalanced amount of fat tissue. So the more fat cells you have, the more inflammatory agents in your body. Abnormal central fat, which is considered more gray fat, has more negative atherogenic, lipogenic effects, particularly in women. So the women with the hips, because we're naturally Mother Nature, puts fat on our breasts, puts fat on our hips or the butt, and that's kind of a pad sitting there because theoretically we're going to have babies and breastfeeding, so you need that backup. But just to have the typical beer gut, we think of a guy or a woman with a big gut, that is actually not as healthy of a fat, because you need some fat, right? Okay, so some of the complications. The problem with obesity is this is a problem. It's kind of the difference between marijuana and heroin. Okay, so heroin, everybody can see is bad. It's quickly addicted. People die, they fall apart at a fairly rapid rate. But obesity is more like marijuana. You do it chronically, it feels kind of good, you enjoy the eating and not exercising, and it causes damage much slower and over time. So you don't need, and it's insidious, kind of like marijuana. Oh yeah, my brain, I'm not as sharp as I used to be, but how can you measure that? Neurologically, I'm not as quick. My sperm is swimming slower. These are harder things to measure with the marijuana, right? So in this way, obesity is sort of the same. What affects you in the obesity world is, and the things to ask when you're assessing a client is, isn't that little Shar-Pei adorable? And that baby, that is so big, cute. But is duration. So have I only been overweight after my second pregnancy? At age 25, let's say. The presence, again, do I have the big gut or do I just have big hips? And the date of onset, have I been obese since my childhood or did it start happening after menopause? So you got to factor in those factors when you're also thinking about, well, how much damage, how much health risks those people might have. We know now, we didn't used to know because kids didn't have obesity or there wasn't enough numbers to even study, but we know that the earlier onset of being obese, the greater risk for intervening factors such as diabetes and hyperlipidemia. Okay, so here's pin the obese tail on a donkey. You can just have a heyday with pin the disorder on the fat, on potential issues that can occur related to obesity. Again, we didn't, back in the 70s, you didn't have a population of kids that were obese. I remember in grade school, you know, there might be this one kid in the classroom and he was odd or he had psychosocial issues of some sort. And they may be gone the next year because where did that kid go? You know, there were things in his life that were problematic potentially. We also know that probably, theoretically, they believe that you guys, people younger than me, are going to be the first generation that don't live longer than their parents. Because we probably peaked out in the 60s on health issues. So let's just go through this list. These are complications of life that have an increased propensity if you're obese or overweight. Doesn't mean this is like the marijuana thing. Doesn't mean you're guaranteed to get them. It doesn't mean it'll happen quickly. Everybody's different, but these are common problems. Hypertension, stroke, type 2 diabetes, renal impairment, dyslipidemia, heart disease, immunologic impairment, gallbladder disease, steatosis, respiratory issues, cancer, gout, orthopedic issues, endocrine abnormalities, if I can say it, ADL limitations. And I know when I was 9 months pregnant, just going into a bathroom stall, so I get in there and shut the door and get it around your gut, it's not designed for 450 pounds. Not that I weighed that much. I was pregnant, even me, at whatever I was, it was difficult. Sitting in a booth in a restaurant, getting in and out of a chair, things aren't designed for the sizes people are becoming. Going up and down stairs, for goodness sakes. Deep vein that should be DVT, deep vein thrombosis, pulmonary embolus, decreased life expectancy overall. And have you ever, somebody please email me the day you're in the hospital and you see a 450-pound 95-year-old. I haven't seen it yet. It could happen, but life expectancy. Lower limb edema, obstetric issues, and cataracts. Let me tell you a funny story. I hate to say this on a video, but just real quick, there was a med students that were helping hold back very large pendulous gut on a woman so the resident could do a pap smear. And as it is with a heavy weight like that, if a chunk of it slips away, the weight of it will draw the other. So the one student couldn't hold it anymore, or it slipped, and so the weight of the pendulous gut flipped out of the other med student's hands and went down on the wrist and broke both the wrists of the resident. Anyway, true story. Cataracts, prostate problems, and general dysfunction in that area. Okay, so let's cover some of these in a little more detail. Hypertension. So data shows the greater the BMI, body mass index, the greater the blood pressure. Now, you will find a 450-pound person with a normal blood pressure. But statistically, if you're lined up 100 people, as you gain weight, your blood pressure will go up. So excessive weight gain activates the sympathetic nervous system and the renin-angiotensin system. Remember the communication from the kidneys. And it initiates changes in the renal structure and function, so it causes sodium to be retained. If you hold on to sodium, you're going to hold on to fluid, you're going to raise your blood pressure. So there's an increased blood pressure in the obese. This eventually, over chronic elevation, causes glomerulosclerosis, damage to the glomeruli in the kidneys, and loss of nephron function in the obese. Increased blood pressure also puts you at greater risk for stroke. So obesity leads to hypertension. It also, this extra fluid volume circulating around stretches out the ventricle, and then you have a left ventricle that's already pumping, working harder, pumping to a larger body that it wasn't designed to pump to. So you get left ventricular dilation. So they have increased risk for PVCs, premature ventricular contractions. Also, study shows if they lose the weight, their blood pressure will improve. That said, there are plenty of obese people who do not have hypertension issues. Again, it's insidious. Stroke. Increased blood pressure leads to stroke. Stroke accounts for 1 in every 14 deaths in the United States. This is the number 2 killer. And a man with a BMI of over 30 is twice as likely to stroke than somebody with a normal BMI of 23. For each unit of increased BMI, stroke chances increase 6%. This was a big, large-scale study. That's a big jump. Diabetes. We know about diabetes. I know you had some good lecture on this before. The risk for diabetes is 5-fold in the moderately obese and 10-fold in the severely obese. Now that said, you will have a very obese person that does not have diabetes, but the risk is massively huge, 10-fold. These are terrible numbers. Fat cells produce necrosis factor alpha and lecitin, which interfere with the function of insulin. So we're kind of designed to have some fat tissue, right? And it's hormonally interacting. We should have some, but we're not designed to have a massive amount. So now hormonally, you're off kilter. The risk of diabetes steeply worsens if the obesity is concentrated centrally again. Lecithin promotes converting fatty acids into glucose by the liver. So more glucose floating about contributes to insulin resistance. And what's an important factor of diabetes type 2 is the number of years, how long they've been obese. Weight reduction in this crowd leads to improved glycemic control. People will improve if they'll lose their weight, as well as their lipids improve and their hypertension improves. Renal impairment in obese may be caused by a decreased renal filtration surface, which may lead to renal sodium retention. We know which kind of leads to hypertension. Obesity leads to insulin resistance. Thus, you have excessive utilizable circulating insulin, which enhances tubular reabsorption of sodium. So also fat, actually, you've got on the other side, just the geometry of it, fat surrounds the kidney and it compresses it, also interfering with its function. They believe excessive weight may be the major cause of hypertension as well as chronic renal disease. Blood lipids. The obese have decreased high-density lipoprotein, the HDLs, which are the good lipids, cholesterol, and increased total low-density lipoprotein, LDLs, the bad cholesterol. Overall, triglycerides have generally been found to be higher in the obese population. And every 10% increase in relative weight, and this is just a statistic, remember you'll still have somebody that's overweight with normal and people that are skinny with abnormal, but statistically you take 100 overweight people, every 10% increase in relative weight, there's a 12 milligram per deciliter increase in plasma cholesterol. So increase atherogenic risk because you have cholesterol, the bad cholesterol is floating around. If they lose weight, it does improve that. And obese subjects, although there's another issue on the side, obese subjects show a blunt response to liver-lowering medications. So even though they're on medications, they don't get as good a response as somebody with a more normal weight. In this class, right now we're not talking about this, but there's breakdowns further within the type of LDLs and HDLs. So obesity is associated with more dense particle LDLs. The dense ones can embed worse in your bed versus the fluffy ones. And we talk about that another time. Heart disease wise, stroke volume and cardiac output must increase with total mass. It's just, I have a heart that was designed for, let's say, a 130-pound woman, and this woman is 190 pounds. The heart, everything doesn't proportionally get bigger to match that 190 pounds. It's all just fat, right? So this poor heart was designed to pump a smaller person, is working a lot harder. If I have a big bone, we got a obese woman that comes in, we look at the chest x-ray. If there's a little petite person under there, that person has worse risk versus a big bone, Norwegian or Samoan individual, they're naturally big bone. And an increase in total blood volume, that's circulating as well, right? So it's working harder. Over time, this extra work leads to left ventricular dilation, and this left ventricular heart failure. Hypertrophy can lead to early heart failure in an individual that otherwise should not have that. So left ventricular hypertrophy, increased stroke volume, and increased cardiac output because they're working harder. I put this kid in here, the swimmer, because when I was a kid, I swam on a swim team. Everybody was skinny as a rail, muscular maybe, but skinny. You just never saw lumpy at all because we were swimming a couple hours a day. So my daughter, we put her on a swim team, and I volunteered to be a timer, and I was shocked. Some of these kids were overweight, if not obese. I'm like, how are they doing this? How are they keeping that weight on and swimming 2 hours a day? Now, maybe they just joined the team recently. I don't know. But it was shocking because you never saw that when I was a kid. So, more about heart disease. C-reactive protein, IL-6 modulates C-reactive protein in your liver. There's some side path. The CRP blood is a blood value. It's a marker of a chronic inflammatory state. If this is chronically elevated, it predisposes individuals to acute coronary syndrome. About 30% of the circulating concentrations of IL-6 or interleukin-6 are thought to come from adipose tissue. So again, you're supposed to have some adipose tissue, but we have twice, 3 or 4 times the amount, so hormonally, they're off. IL-6 contributes to chronic low-grade inflammation, which is the underlying problem of heart disease. Losing weight decreases CRP and lipid values, so that can improve matters. Immunologic-wise, there's plenty of studies on this. Obesity is a major contributing factor of post-operative septic wounds. If I end up with more fat, I don't necessarily have that proportionally more vessels. So adipose tissue is traditionally poorly vascularized. So if I get an infectious process or I'm trying to get antibiotics out there, it's harder to heal. And not only that, it pulls, it strains things. So a large amount of adipose tissue places strain on subcutaneous sutures, impaired healing, and increased risk of dehiscing, meaning the wound opening up. So you'll see on obese individuals, a lot of times they'll put retention sutures. You'll see this large plastic pieces on top with a wire going all the way through the levels of sub-Q, and then leaving it open in between so it can kind of heal from the inside out for fear of infection and dehiscing wounds. Being obese increases the risk significantly of needing reoperation. Gallbladder disease, gallstones, they occur 3 to 4 more, oftentimes more often in the obese, and this increases as you age and with increasing obesity. By age literally 60, 1/3 of all obese women will have gallbladder disease. Excessive cholesterol is likely to form those gallstones. So if they're overeating, they obviously have more cholesterol floating around. It's just sludge, basically. Obese bile is more saturated with cholesterol, so it's more stasis, more likely to sludge and crystallize in there. When they look at obesity-related gallstones, it's primarily cholesterol. Ingested fat is partially synthesized into cholesterol. So because the cholesterol is supersaturated, the bile becomes more stasis, less likely to flow out nicely. Steatosis, fatty liver, it means fatty infiltration of the liver, is associated with obesity. It can lead to scarring chronically over time, which can lead to cirrhosis in the obese population. Have I missed an organ here? Oh, the lungs, of course. Respiratory disease. Increased fat in the chest wall and abdomen reduces vital capacity. And total lung capacity are diminished. So they tend to, so not only are you pulling more weight going up and down the stairs, you're working harder than your body was designed for, but you also have less room for the lungs to expand. Asthma is far more likely to be diagnosed in obese children. They're more likely to wheeze. So it's not so a couple reasons, a couple problems. If they're out exercising and running around the neighborhood, that increases your lung strength. So just proportionally, you may have a fat kid that's out running around the neighborhood. Okay, fine. But in general, the obese kid are less active. If they're not running around outdoors, they're not also exposed to allergens. Kids that run around or playing in the dirt, they're doing things all the time, get exposed to environment in general, so they're less likely to be allergic to things. Wonderful studies were looking at Japanese kids that live in high rises, and you compare them to kids that grow up on farms. The farm kids they don't have asthma, they don't have allergies, they're good for everything. So I love this one, Pickwickian syndrome. Nobody says that anymore, so I love using it because it's technically interesting. But now you'll hear people talk about sleep apnea. It's shorter and simpler, but Pickwickian is much more interesting. Or obesity hypoventilation syndrome is the other title. The title Pickwickian syndrome was noted in the famous book, what was his name? Charles Dickens wrote. He talked about the somnolent Joe, the fat boy, in the Dickens Pickwick Papers. Okay? So there was a character in this book that was a kid that was fat, and he would just fall asleep. He'd be doing whatever and just fall asleep because he was so exhausted. Now we know, because the child would have had sleep apnea, and they don't get good sleep at night. So there's resultant hypoxia and daytime sleepiness and tiredness and crankiness. You can't think straight from lack of sleep. What happens is there's this extra tissue in the throat, in the uvula area. So when they sleep on their back, and you get that deeper sleep, you go into the deeper sleep, the tissue collapses on it. So you hear the snorts. Snorers are at risk for this. And then you'll even hear it, they put it in cartoons all the time, movies, and then they kind of wake themselves up a little bit. What happens is they never get that full deep sleep. They get their CO2 builds up, they get hypercapnia, CO2 goes up, then the hypoxia drive kicks in, and they have apneic period. So it's causing damage over time by being repeat apneic episodes, and your CO2 jumping high, but you also can't live like that. You have to get full sleep cycles. You have to, or you end up damaged. We had a morbidly obese faculty member where I used to work, and this is before sleep apnea got more popular, the knowledge of it anyway. And she was having SVT. Well, first of all, the students were complaining because she was falling asleep during their skills lab for health assessment. And they're like, really? But she's just falling asleep. Okay, that's hit number one. Number two, she was having supraventricular tach. She was having SVT bursts. So she's having her arrhythmias. So finally, some doctor got smart enough, you know what, we better check your sleep apnea. So sure enough, she started losing weight, got on sleep apnea monitor, and boom, all better. Cured, and much, much better. There's a big study in 2013. In the study, 4.5 hours sleep had fat cells. If those people, if you don't get as much sleep, you are 30% less responsive to insulin. So can you see how this compounds a problem? So if I'm not getting good sleep, I'm more likely to be type 2 diabetic. So not only am I overweight, which I talked about the risk for diabetes, there's another risk factor. Not getting good sleep puts you at greater risk for type 2 diabetes. And obesity puts you at greater risk for not getting good sleep. You can see it all falling together. Those with 8.5 hours sleep, much improved on their insulin. Okay, let's talk about cancer. Men who are 40% overweight have a 1.33 times greater risk of cancer, and women 1.55. In other words, both of them increase risk for cancer. What are the risks? You're more likely to see, this is a huge study, cancer colon, kidney, breast, endometrial, ovaries, and breasts. See, there's two ovaries. You have two breasts, okay? For women, in general, excuse me. Men had greater risk for colorectal and prostate cancers. Women slightly increased risk endometrial, gallbladder, cervical, ovarian, and breast cancers. Fat cells produce estrogen. And of course, we are supposed to have some estrogen, right? And there should be a balance. So we're naturally supposed to have some fat tissue. But with too much fat tissue, too much estrogen, and it is an increased risk to breast cancer. They're not clear if the cancer is from obesity or the high fat content and the high calories diet. Gout is a well-known complication. This has been written up by Shakespeare and other authors for hundreds of years, thousands of years, maybe. But gout occurs, and this is a very extreme photo. It can be more subtle in people's hands, but just to show it on a slide, I put in a fairly extreme case. The liver produces more uric acid than it can excrete from eating high-rich foods. The dictator in North Korea, I remember a couple of years ago, they were complaining he was limping. It's like he's limping. He's only like 30 and he looks more like 55 because he's overweight. They're like, oh, he's just eating rich foods. He probably had gout was the reason he was limping. The problem is your kidneys can't excrete it. It's too much. So it crystallizes in the joints, which leads to pain. So all that excessive uric acid from too rich of foods needs a place to go. They're also at greater risk for arthritis. As your weight increases, there's an increased risk for osteoarthritis. Men are at a greater risk for gout at a lower elevated uric acid level. Women tend to need to be more with a BMI of at least 31, whereas men can be a BMI lower and start having gout. And of course, orthopedic issues are simply gravity and the burden on joints and bones that weren't designed for that weight. Increased weight adds trauma to weight-bearing joints. Weight loss will markedly decrease the chance of osteoarthritis. And being overweight is a major predictor of osteoarthritis of the knee. So it drives me crazy when I see an obese individual and they say, well, we're going to do a knee replacement. I'm just like, okay, that's nice, but shouldn't you be required to lose 150 pounds? Then we'll do it. Shouldn't it be a trade-off? Years ago, we had a guy that was morbidly obese, and I remember Dr. Lamia did open heart surgery on him. And we just gave him such a hard time. What are you doing? Why are you doing open heart surgery on this guy? He doesn't care. He's morbidly obese. He goes, because he came to my office a year ago, and I refused to do surgery on him because it was pointless if he's not going to take care of himself. And I said, come back to me when you lose 100 pounds and I'll do it. He goes, he lost 100 pounds. So he was still 350, but I guess he used to weigh 400, 450. He was a chef, and he liked cooking, evidently, and eating. So we were all laughing because he goes, I had to. I told him I would. When postmenopausal women lose weight, they lose more bone mass than non-dieting women. So losing weight, and there's not a lot of research out there on this, but losing, and I think if we did the study, which people don't want to do, on the lap belt people, it's very unhealthy to weigh 450 pounds, okay? But they gain that generally slowly over years. I believe, and I do not have research to back this, it's dramatically unhealthy to lose 100 or 150 pounds in 6 months or a year. Because you're tearing your body down. There's a few studies like this. The most postmenopausal women are more deleterious to their bodies to lose weight at a rapid rate. It's much better to just slowly, like exercise a little bit and cut your calories back slightly to get that body back into shape. Endocrine abnormalities. When obese, you're more irregularity in your menstrual cycles, more likely to have polycystic ovaries, and more likely to have trouble getting pregnant. When pregnant and obese, there's increased frequency of toxemia, like preeclampsia and hypertension, gestational diabetes, and have a stillborn or a child with a birth defect. And there's, of course, the ADL limitations, functional impairments of activities of daily living. These are related to sleep issues, recreational issues, work, and social interaction. It's a company picnic is the social thing in the company is the softball league or the kickball league or the baseball league, and you're too obese, you're not going to interact in the same way. Severe obese have increased absenteeism and unemployment at work. So employers recognize this, and so it's harder for them to get jobs because people just assume, even if they are a high flyer and active individual, people assume they might not be. So there's a certain amount of prejudice as well. But statistically, they're sicker more. They live in a world that they basically aren't the right size for. Fitting in chairs, buying clothes, walking upstairs, bathroom stalls. Although, on a positive note, the obese are more cold tolerant. There was one study where they were doing research, it was a military thing, on how cold people could tolerate ice. So put guys in ice buckets and see how long they could take it. And they had a really big obese guy, and he just sat there. He didn't care. They just came up and got him out of the water. He was cozy. He was a little walrus. Okay, what about children? Oh, don't get me started. We could have a whole lecture on this, but hypertension, obesity is a leading cause in kids. You never saw hypertension kids in the old days, and now we are. Dyslipidemia, obesity linked with accelerated atherosclerosis, autopsy children who died from unrelated causes. So somebody did a very nice study, looked at the autopsy of a variety of children that died, trauma, drowning, swing accidents, what have you. And if they were obese, there were tons of fatty streaks already on the vessels. Obese children have increased levels of hemostasis and inflammatory factors, increased heart rate and cardiac output and cardiomyopathy. You got a 15-year-old with already a large heart. What's that going to do? It's horrible because it's a form of child abuse, if you, depending on your opinion on that, because he didn't do it. He doesn't feed himself. The greater the obesity and the earlier the age of onset, the worsening the symptoms. So, inflammatory factors include fibrinogen, plasminogen activator, and C-reactive protein being elevated in that population. So the negative health effects of obesity are not immediate. This is the problem. It's insidious. If you look at longitudinal studies, less than 10 years, there's little association between weight and outcome. In other words, we're tough, man. Especially if we're young, we can tolerate this for quite some time. 10 to 20 years shows weak association. Greater than 20 years, a strong association between weight and adverse outcome. So it's very uncommon for a child who's obese to become normal weight. So what you generally have is people that get overweight, like in their 50s, through their middle age, you don't see as many problems. And if you don't start till then, you tend to get morbidly obese versus the youth and more years of it. Obesity at younger years affects intervening risk factors, diabetes type 2, hypertension, more so than if you get obese in your older life, like postmenopause. Chronic obesity, twice as likely as normal weight individuals to die prematurely. Don't get me wrong, the underweight also have greater health risks if they're too skinny. Smokers have lower weights and increased morbidity and mortality. And persons with chronic diseases may have a lower weight as well. So then they're, of course, unhealthy, like a chronic disease. A video here I'm not going to show because it's a recording and it doesn't make sense. So I'm going to skip from here. And thank you for watching our lecture. I hope you enjoyed it. Go back to the recording. All right, you guys have a good one.